when the world has got you down. And
Alzheimer's sucks. It's an equal opportunity disease that chips away at everything we hold dear. And to date, there's no cure. So until there is, we continue to fight with the most powerful tool in our arsenal, love. This is Love Conquers Alz, a real and really positive podcast that takes a deep dive into everything Alzheimer's, the good, the bad, and everything in between. And now, here are your hosts, Susie Singer-Carter and me, Don Priess.
Hello, everybody. I'm Susie Singer-Carter.
And I'm Don Priess, and this is Love Conquers Alz. Hello, Susan.
Donald. Hi.
Yes.
How you doing?
You have
Happy
something to say to
Thanksgiving.
me? Do you have words?
I have a lot of words.
You have words to say?
I have a lot of words today. I have so many words. It could take a long time. But
Yes.
It is Thanksgiving weekend. So I'm grateful for this show, this platform, to be able to speak to everybody out there that needs a community and wants to be a part of the community. It's an honor, so I just wanted to say that. And I'm kind of grateful for you, Dawn, because you're my BFF.
Oh, my goodness. But just kind of, though.
Kind of, yeah.
Yeah.
When I say kind of, that means
mutual.
greatly.
Yes. And vice versa.
Yes. So
Yeah, no,
it's been an interesting year. We've got things to do and missions
We
to
do.
accomplish, and I am wearing my happy face. So, fake it till you make it.
Yeah, absolutely. Hopefully
And
it's not too much faking, yeah.
look at that. I have a happy
What you
face
got there?
necklace.
Whoa.
It's a happy
so
face
that is
necklace.
the theme today.
That
is
theme
today's
today is
theme.
happy faces.
Nice.
And we have them, right?
We do.
It's
we
good
do.
to be
We have
happy.
faces. Well, when you consider the alternative, it's actually better to be happy. I just learned that. Just
Took
now.
you a lifetime.
It did. And just now, due to
Just
all
now?
the happy faces, I learned that it's better to be happy.
Look at that.
So,
I'm like a influencer.
yeah.
Can I get some sponsors now?
Yeah. Well, we'll try any way we can.
Yeah. So,
Wow.
So I have started the documentary. I'm 3/4 through of the script for No Country for Old People. And
Yes.
I'm deep in it. I'm like waist high in this world. And it's, wow. The deeper I get, the deeper it goes. It's like there's no end. And
Well, because when you were going through it also, you had no perspective. You were in it. And now you're looking at it and and laying it all out and going and it's even more insane, I think, than you thought it was at the time, even though it was pure insanity then. So
yeah. It's a lot. It's a lot. And the more that I talk to the people, as opposed to talking to caregivers and talking to people in the healthcare industry on that side of the table, I mean, it's just as bad. It's, it's just as bad. Everybody's got their hands tied. And that's why I'm so excited to have our guest today, because it's good. We need to hear other perspectives. And, I mean, honestly, no one is a winner except for the very tippy top. Nobody wins in this system right now. Everybody is suffering. So, why don't you introduce our lovely guest?
I'd be happy to. Ann Kenny, MD, is a professor of medicine with specialty training and board certification in geriatric medicine, plus palliative and hospice care. A practicing physician for almost 30 years, she's been recognized by her peers as a top doc in geriatric medicine. Dr. Kenny lectures to both healthcare professionals and the public on aging-related issues such as osteoporosis, exercise, nutrition, hormone therapy, frailty, and death and dying. She's the founder of Together in Dementia, a website and educational service regarding living with dementia and caregiving. And she's the author of Making Tough Decisions About End-of-Life Care in Dementia, an important and compelling resource that provides valuable tools and lets caregivers know they are not alone. Sounds like she just might be qualified to talk about our subject today. So, without further ado, let's say hello to Dr. Ann Kenney. Hello, Ann.
Hello. Thank you for having me. This is so wonderful.
Oh, thank you for being here. You're so qualified and you've done so much. And like Dawn said, I'm not going to go all over it, but I do have to like dig a little bit and say, what is a top doc? How do you become a top doc?
A top doc is just something that gets voted. And I used to say it was that my mother got multiple votes and stuffed the ballot box. But then when she died from dementia, I couldn't say that anymore. I have no idea what it is. It's just a slight recognition. It's kind of, are you a doctor's doc? Would a doctor send their family member to you? I think is how most people would.
Oh, that's so wonderful. Wow. That's a high honor. We're really lucky to have you today. No, that's
stuffed the ballot box. So.
Well, then that's a good mama.
Then she's really smart.
She might be just a little partial.
What brought you into gerontology?
Believe it or not, I actually fell in love with it when I was in medical school. I had a lecture series. Jane Potter was coming back from the NIH and did a short little series. And as soon as I heard about it, I was hooked. It was this balance of medicine and rewritten, a little bit of psychiatry. It was a little bit of everything, but for the whole person and their whole family. So it was the first time I really saw medicine approached much more holistically and not kind of, just the lungs or just the kidneys or just whatever.
Compartmentalized.
Very compartmentalized. Yeah. And, they were telling us in medical school that when you pick a specialty, really start to think about what's going to be your bread and butter, what you're going to see, and that will be what you spend most of your days doing. And so for geriatrics, most of my days would be working with older people who likely were living with dementia. And for me, that at that time, this was, again, back in the late 80s, early 90s, that was people who really had no voice and were really underrepresented completely. Love Conquers Alz was not out there yet. There was very little going on to help. And so it was kind of that combination of it was holistic and that it was this underserved area, which really offers you a lot of opportunity for creativity and for approaching things a little differently. And that was very appealing to me.
It's very tribal because it's comprehensive. You're dealing it's both ends of the spectrum. When you're dealing with parents with young children, you're dealing with the whole family, and when you're dealing with someone who's elder, you're dealing with the family as well, because
absolutely
you have to.
And some people don't like that.
Yeah.
And I thought that was like, you really come at it as a team. I hope that you really come at it as a team. And that I wouldn't be the head of that team. I would just be a piece of that team. And what I loved is once you're, often in doctorhood, people can get put as a head of a team when they shouldn't be. They should just be part of the collaborative team that's doing the best care possible.
How do you communicate that to a family? Because I think when people naturally, they come in and they expect you as the doctor, you are the authority, you know everything, you've done this before. So what do you say to a family before you start dealing with them?
First, when I first meet people, I say, we need to get to know each other. I really want to know who you are. And they'll say, oh, well, I have high blood pressure. And I'm like, no, who are you? I need to know your story. Yes. And I know that, the beauty of people coming, I feel so honored. The beauty of people coming to a doctor's office is almost like going to see a spiritual person or whatever. People are usually so open and so vulnerable and so willing to share who they are. And so I have this huge privilege that people will open up so quickly. And so when they start to tell me about their medical issues, I'll say, I need to know who you are. And then that will help me decide what gets offered. And then a lot of times they'll say, but I just need to know what you would do. And I'll say, okay, I can give you some choices, but then I want you to start a dialogue back and forth with me. Which one resonates? And then we'll go do a deeper dive into that. But if I say your choices are X, Y, and Z, you can see the light in their eyes when Y is what they're like, oh. And then so we then kind of start to talk more about why. If I lose them again, then I'll back up and go back to X, Y, Z, and we'll talk a little bit more before we kind of go down a different road. Just because there's so many choices, and I say that there's so many choices. There's no one right way. You need to trust your intuition and then guide me with what information you need. I need to know how this system fits into your life, your family life, your holistic life.
You just touched on so many things to unpack just in what you just said, because, I mean, first of all, does everybody have the time or take the time to get to know their patients, like you're saying? And it is an honor to have people come and trust you. Honor. It's also a responsibility, too. Well. It's a great responsibility. Yeah. And so, I can remember my grandmother, her greatest thing was going to the doctor. And, at that point in her life, it was like, I'm going to the doctor tomorrow. It was heaven.
And honestly, people will say, oh my goodness, my mother hasn't spoken this eloquently in months. I'm like, because, they're going on this big outing and somebody's going to listen to them. Of course, they're bringing their best forward. Again, I knew that, and I felt so privileged that I got to be part of that. And I took it seriously.
But you're also intuitive.
I hope
you're
so.
Intuitive. You touched on that. You're saying, first of all, you get to know the background, which is so amazing, because I try to say that to so many people in my mother's journey, is that, and even when my daughter had an issue with her baby prenatally, and I kept trying to say, this is the data, but now let's see how that data fits into what's going on with you. Right. And that's the same with anybody who has dementia, Alzheimer's, anything, cancer, whatever. Right. But we're talking specifically about older people and dementia.
And the hardest part about dementia is there's a point where you really lose your voice. I mean, you either metaphorically or figuratively or actually. And so then knowing more of that, who they are, and that's why it's so wonderful to have the whole family there. It's fascinating because you get to see family dynamics, and often you have to kind of confront some of those family dynamics and say, okay, but that was then. Now how can you get to a new place as the daughter or the son or the sister or whatever? Because now we have to become this individual's advocate as a collective. And if we don't, I get that you're still mad about something that happened when you were 8, but let's put a pin in that for a minute, and we'll get back to that, because that's part of who you are as a caregiver as well. Like, can you kind of separate from that, come forward to help the person that's in front of you? And if you can't, that's okay too. Then we have to make sure that somebody else comes forward and does that caregiving part. Right. And we still need to take care of you, because you're still probably going to be the voice. And I just think all of that is fascinating and exciting. And it takes a creativity. And I think it usually, as much as, I know you've been on the caregiver journey. I was on the caregiver journey. I hated it. But at the same time, I grew from it. And so I think sometimes when you go through those hardest things, that's your hero's journey. And so I love when the family is there. And I not only get to help with the person living with dementia, but I get to be witness to hero's journey after hero's journey after hero's journey. And I think your podcast name says it all. Love Conquers Alz. We all finally get to that point where we realize, it boils down to, can I get to that place of love? And then everything kind of opens up in such a wonderful way.
I don't know if you got a chance to see a film that
Yes.
we did, My Mom and the Girl.
Lovely.
You
Just
did?
so
Okay.
beautiful.
Thank you. But I say that year was the hardest and the best year of my life.
I'm
and
with
I
you
think,
1,000%.
Right?
Absolutely. My mom's
Yeah.
journey with dementia was hard, but transformative. And
Transformative.
It was so
I'm such a better person now.
I used to have an emotional range about this wide, and after, it won't show on the screen. It's so, I may have gone to some low lows, but I went to just such new places. It was amazing.
Me too. I mean, I told my mother, like the day before she died, I said, I love you so much. You taught me how to live, and now you're teaching me how to die. And I was so afraid to die my whole life. My whole life, since I'm 3 years old, I would have anxiety attacks, and my worst thing was losing her. And she, despite this horrible 6 months that she went through at the end, she had such this joie de vivre and this like just the love of the love, and that just showed so deeply and so strongly that you can't deny it. I mean, Don was there during the journey, and he can attest to it. It was like you would think that anybody that was going through what she went through would have just crawled up into a fetal position and just melted it away. And instead, anything that was just slightly wonderful, she would just light up.
My mother was like that too. There was definitely not great things, but she never lost her love of living. She, just like your mom. Yeah. Yeah.
Oh, well, it shows in you, by the way.
Yeah, and you too.
Oh, thank you.
It's funny because you both lost your mother in a similar situation, and I think I unfortunately I think you as a doctor may be in the minority as to the way you look at things like this.
Maybe.
And when I say that is like, how important is it to know who that person was? Because the doctor comes in and they only see the person who they are now. Sometimes the doctors and even the nurses, they just don't look at them as a person. They look at them as just what's lying there right now.
I didn't realize that I was maybe a little bit different as a doctor until I was my mother's health advocate. I learned how to doctor. I did research for about 30 years in the morning. That was on people with frailty and osteoporosis, but mostly frailty. So these were cognitively intact individuals, and I wasn't their doctor. I was the research doc, and they were coming into my clinical trial. So it was a little bit different relationship, which was nice. So they were there to help me, and they made sure that they helped me in all kinds of ways. They were just, their voice. They had a voice, and they had a doctor to hear them, and it was wonderful for both sides. And what they would do is they'd go, "Honey, this pill makes me feel like or this thing you're doing to me is demeaning," or blah, blah. And they basically trained me. And so in the afternoon, I would go take care of people living with dementia and their families. And because the voice was, I would say, well, my other patients are telling me that this antibiotic isn't great. And they because they had their own voice, they told me that it takes about 3 days to get over a urinary tract infection. Most of the time, sometimes it goes into something terrible like sepsis, but most of the time, most our bodies can take it. And what those people with frailty taught me, and even though their bodies were frail, their spirits were definitely strong, which I think a lot of people with dementia spirits are strong, but they just don't have the voice anymore. And they taught me that the body is really very resilient, and that less doctoring as we age, less medicalization is so much better for an aging body, that the body will actually do really well. And so they really taught me to kind of be less of a medical doctor and more of a listener, and more of a what are you telling me, and then let me look for the symbolic meaning in that, let me look for the under meaning in that, and then let's find a way forward that fits. And sometimes there was like a sprinkling of medicine, sometimes a sprinkling of therapy, sometimes community. But I learned that the best medicines are not medicine. And so, and then to your other point, Don, you said, I found as I was developing this palliative practice, it takes a couple of minutes to get to hear someone's story. Just like, so if you start with a story, the rest of it goes so much more smoothly. And so for me, it was a time saver to know who I was dealing with. It didn't take me more time. It took me less time because
that makes so much sense.
Because that, like, a family member would come in and maybe be saying, and I'd say, what I heard when you told me the story of your dad, who again might be living with dementia and wasn't able to, is that he had, and then I would name what I heard. He had this kind of spirit or this kind of belief. And so I'm going to say, why don't we, what do you think about this path, which might align with the way he was living up to the point of having dementia? And you could see their shoulders would go down and they'd go, oh, is that an option? And I'd say, of course it's an option, but I think when you don't get to know the person, we almost do a one size fits all. And one size fits all does not work in almost anything, especially in medicine.
But how do we get the medical community to take on this path? I mean, because this is not the norm. This is absolutely
and
not
I agree
the
with
norm.
you on that. I don't think it is the norm. And so 50 years ago, cancer was often not told to you by your doctor. It was often kept from the family member. It was all secret and people didn't talk about it. And I think that's where we are with dementia now. And what happened is the people living with cancer became their own advocates, and and they moved the medical system forward. And so I think some of us are doing the same thing with dementia.
Yes.
Is we're getting people living with dementia early in their dementia more voice through some organizations. Podcasts like this are becoming where people are going to more than their doctors to get information. Mm-hmm. And honestly, I feel like we need to demedicalize Alzheimer's a lot, much like the cancer movement kind of said, look, I'm more than a cancer diagnosis. I'm a whole wide person. Right. And so I think it will get right-sized when we all kind of start going, oh, dementia is just like, why can't it be like cancer? Why can't we say, oh, the person with dementia is this whole big old person. They're changing, no doubt. But they still have their strengths. And, we have to, as I get older, here's my reading glasses. I grab them. If I start to change how I'm going to walk and I need a walker, I'll be the first to get a walker. I'm going to get hearing aids as soon as I need them. That's adaptation. Yes. I think we're going to get to the same place where we see dementia as a chronic disease, not as this immediate death sentence. I know I wrote a book about end of life, but I see dementia as something you live with very well for a lot of years, and then there's a point where you start to die from it. And if we demedicalize it, I think we die better from it, that it's not as turbulent. But I think once the lay public understands kind of the living with, and that when it gets to the point where there's that adaptation becomes a little bit more futile, and we need to adapt more to the dying body, not the living well with.
No, I think you're absolutely right. And I think, and again, I'm going to sound like a broken record, but I think it's very similar to children. And, when your children are gaining skills as they grow, babies come with none, basically, just their autonomic skills, to breathe, to heart therapy. But they're gaining skills, and we don't put expectations on them until they get those skills. Right. We guide them till they get there, and we do it hopefully with grace and with love, and we realize that they can communicate without words, and we can communicate to them without words very well.
Absolutely,
right?
Probably at least 90% of communication is nonverbal.
That's right. And so when, on the other end of the spectrum, when someone has dementia and it's advanced and they start to lose more skills and more skills, they're just losing skills, but that person is still there.
Right. Always. To the very end.
And you just have to approach them with different skills as you would a baby, a child, a toddler, and so
And
on.
I think the hard part is that we as a culture have lost kind of what natural death looks like. Once antibiotics were invented, kind of the shift made it to the hospital, and a lot of deaths didn't happen at home anymore. And I think about 100 years ago, people died fairly gracefully at home. It's been in the last 150 years, or 50 to 100 years, that we've kind of made that transition to dying in a hospital, which most people don't want to do. They would rather be surrounded by family, but we've almost lost our ability to know how to die at home. Like, we push people into hospitals. We don't have the skills that people used to have, that just sitting at the bedside is often the best medicine. And the body knows how to die if we just get out of the way. You sleep more, and when you wake up, you're probably going to have some of those good moments that, the best moments that people who live with somebody with dementia know, those moments when all of a sudden you're like, oh, yay, I get this big smile, or this,
you get these
or
gifts.
big squeeze, or whatever.
I love you out of nowhere.
Of course, not if they're shot up with morphine,
Well-
or if they're constantly, there's times where that's probably overused, or not used at the right time.
And I'm honestly, this is where I'm going to sound like I'm talking out of both sides of my mouth, but I'm actually, there's two times that I think we undertreat people living with dementia, and one of them is pain. And I think morphine at the end of life is a great drug, and even at the moderate towards the end of life. There's a lot of medicines that have very long half-lives, and if you give them to people with dementia, they hang on way too long. But morphine is pretty like quick in, quick out, and so you can kind of use it and then get it out of there when you don't need it anymore. So I think, Don, what you're saying is like really high doses of morphine, but low doses.
Yeah, just basically
to snow somebody.
It's like, here, let's just shoot.
Yeah, you don't need to snow people.
Well,
But Suze,
Yeah,
by
I'd
the
like
way,
to get-
I don't see Suze. I don't see your camera anymore.
that's okay. I'm on. Don't worry.
You sure?
Yep. Don't worry. Last time, I promise you I'm on. Yep. Yeah, we'll get into that, Dawn, because we need to segue into that. I kind of want to know. So for me, when my mother went into the hospital because of a stage 4 wound, and that went into sepsis, and that went into pneumonia, and that went into low kidney function, it triggered a lot of situations that could have been treated better and would have given her last 6 months a better quality, or maybe even another year. We don't know, because, the day before she went into the hospital, she was, as my mom ever was at that stage, right? So I think, again, and it goes back to what you said about looking at people as individuals, and what is their base, and who are they, what would they like, and a lot of, as much as the public doesn't understand Alzheimer's and dementia, the medical field in general doesn't really understand it either.
I say you get on the medical conveyor belt, and if you come in with this, you get that. Right.
Yes. I mean, I literally, when my mom was in the hospital during COVID, I mean, I wanted them to FaceTime so she would know that I was there. And one of the charge nurse said, "Honey, she doesn't talk." And I thought, oh my God, you don't get it. Right. As most people don't. Right. And it's really important that people do, because there's so many first responders that make mistakes. And my mom ended up locked up in a mental ward for 7 days, plowing her with Depakote, and that's when she never walked again after that. And she was very healthy physically.
And that can take somebody living with dementia, and if you don't do things just quite right, there's this kind of gradual decline, but you can make big step-offs. It was going to go one time, but at the same time, maybe later, if she had been...
Later. Right. And
I would love to kick that can down the road.
Right?
Yes.
Wouldn't we all? I mean, this is the thing. It's like, yes, it's a sentence. But in a way, we all are sentenced,
absolutely.
Right? So it's just a matter of time. And so all we can do is honor the time that is now. So if my mother, I have no idea how long, like my mom lived with it for 16 years. So we have no idea how long one has with this disease, when it's going to, kick to the next level. But in the meantime, let's honor the level that they're at now and not kick the can down or kick it closer, because we all deserve the time that we have here. I mean, we all know we're on borrowed time, and that's the nature of this game called life.
That's the human existence.
And that's the human existence.
But your spiritual mother was still in there saying, okay, honor this part of me.
I'm not ready. And my mom kept saying she wasn't ready. I kept saying to every doctor, I promise you, I'm not living in, la la land. I know my mother will die and will die probably soon. But she's not ready right now. I'm telling you, I know her. She's not ready.
So, I mean, there are statistics on that, and I walk into a room and I say that to people. I say, I can tell you where your mom is in the dementia journey from a functional standpoint, and that can help guide you. But no matter what, 10% of people want everything done till the very end. And that's a fine decision. And in my family, I come from a family of 6 kids, and there was a conversation I needed to have with them about where my mom was. And I wanted everyone to be on the same page about what we were going to do and why we were going to do it. So I went around the room and I asked all of us to say what we would want if we were living with dementia. And I had one brother who really valued cognitive acuity. And so he said, as soon as I show any signs of cognitive loss, I want to be put on an ice floe and set out to sea. And at the other end of the 6 kids, I have one who said, God gave me this breath. I want to take every breath that God gives me. And so we had, in my 6 siblings, I want no cognitive loss to, I want to live every breath I am given no matter what.
Exactly.
And then there was the other 4 of us somewhere in the middle of that, obviously. And so everyone stated their opinion. And then I said, okay, so now we know where we're all coming from. Now, what do we all think Mom would want? So let's all say out loud where we think Mom would be on this. That was pretty consistent because my mom was pretty good at talking to all of us about what her life wishes were. And I loved that everybody could then, because I think that as the conversation started, everybody was coming at it from what they would want, at first. What would they want? And I think that's, Susie, what you're saying is sometimes the doctors are like, oh, this is our reality. Well, we're jaded. We're in the hospital. That's a jaded reality. So by getting my 6 siblings to talk about their wishes and then reframing it to what would Mom want, everybody was easily, and then we all respected that this is hard on the other 5 because it isn't quite what each of us would want. So it actually built compassion between the siblings and still kept the focus on what my mom wanted. And that's all I needed. I needed everybody to come together on that.
Be on the same page.
And I wanted us to be a family when it was all over. And I think we got there. But again, it was part of that huge journey that is not necessarily always fun or always easy. And that was one of our tough conversations, but I think it was really helpful.
It sounds like it was. And, I to that point, I remember, and I've talked about this, there was a palliative doctor that called me when my mom was in the hospital, and he said, listen, anything that you say is fine, whatever you want, I'm here to help you, but, I'm going to ask you this question. What would your mom, before she had dementia, what would she want? And especially because my mother had it for so long, what my mom would have said at 70 was a lot different than what she was saying now. And so it's not a fair question sometimes because when someone has it a long term. When my mom was 70 and full of piss and vinegar and she would go and visit my stepdad or my step-grandpa in the hospital and she'd go, Susie, when I'm, just she didn't want to be in a home, that whole thing. Then once she got dementia, and once I walked over the bridge and she embraced it, she was so happy. And every time I would see her, I'd say, Mommy, how are you? And she'd go, I'm great. I'm alive. life is good. And she was so happy that I had to look at the stage that she was at and not where she was when she was 70 and full of bravado and full of that kind of thing. I was like, ugh, because that's so far in advance.
Right.
And I said that to people when they said, in the hospital, like, your mom's 89. I mean, and I'd go, okay, I get what you're saying. But when you're 89, you tell me how you feel. Do you want to just go?
89 is just a number. Right? It's just a number.
Exactly.
Absolutely.
Yeah.
There's plenty of people older than 89 who are living
very
very
full
lives.
And I think, I'm very fortunate because my day job was to see families and people living with dementia. And I got to see people who were doing it beautifully. And I got to see people who weren't doing it not so beautifully. And so I knew, what's the difference? It's not the disease. It's the people living it, right? And your mom embraced it, like you said. She embraced her today, and that's wonderful.
She did.
Not everybody does, but
she did.
Yeah.
No, they don't.
There's a very natural question that people ask, and it's similar to what we had a little similar to, is basically they ask you, the doc, well, what would you do if this was your mom? What would you do? Is that a fair question? To the doctor?
Well, I think I would be careful what doctors I ask that to.
Yes.
I say this all the time. If you go to Midas, you're going to get a muffler, right? So if you're going to a heart doctor or you're going to a lung doctor, you have to remember that what they see and what you're experiencing may be two different things. And there's a lot of doctors who will propose doing all kinds of interventions, but they say that if it were them, they wouldn't do those things. So I think it's tricky. I think you have to, if you really trusted somebody, I would ask them that. I think that's fair. If you feel like you know them enough and you like their judgments. But I think a doctor that I don't know, I'm not sure I would ask that to.
Dawn, it's like having somebody, like going to somebody that you don't know and saying, how should I dress for the Academy Awards? What if they have the worst taste ever?
Don't come
what
to
if
me
it's
for
not
that?
the same as yours?
Why
would you?
Hard. Yeah, but it's so hard because sometimes the doctor asks you, what do you want to do? And it's like, I don't know.
Oh, I got that all the time.
I'm not a doctor. How would I know
I think what I would say is,
as a person?
I think what I would ask them is, can you outline maybe the 3 top choices and tell me what happens if I do that and if I don't do that? I think that's what you're getting at, is what happens. Because what people say to me is, I don't want to regret that I did too much or too little. How do I know if I did too much or too little? So I like to tell people, okay, if we do this, this, say this is the most invasive, the most intensive, this may happen. You may have a cure. I mean, not for dementia, but for something else. You may have a cure, but here's how much it'll cost you. This is the burden you have to go through.
Yeah.
If we do something in the middle, you'll probably get this. Probably is a big probably, but we can still turn around and do this one, or we could still back off. Or if we do this one, and then I think you need to know, is it what happens? Is it is there no going back, or can I do things, and move them around? And so I'm often saying to people, okay, if right now you don't want to do anything that invasive, why don't we just watch it for 3 days and reevaluate? And in 3 days, we'll decide what we're going to do. And honestly, it's the same with, I know your mom went through sepsis. Sometimes people will say, well, if we don't treat this, there's a really high chance she'll die. There is a high chance, but there's also a chance she might not die. And they don't tell you and we could kind of stop this whole snowballing medications causing side effects by giving it up to, let's see what she's got. Let's see how well she's doing and see what happens. But
it's a risk reward. It's a risk reward thing, and
in Susie's case, it sounds like they didn't give her the options. They gave her we're going to do this because if we don't, this is going to happen. Or you had to ask for option. You had to ask for option A. They only told you option C and never told you option B of choices. Yeah.
Correct. And that comes down to the system, and that comes down to lack of staff and lack of time, and and all that stuff that they're just trying to get through it without getting pinged.
Right.
Without getting for liability or anything like that, and not to get, mercenary here. But the truth is that, when my mom went into hospice, and this is my next question to you, I had no idea the difference between hospice and palliative. I was just learning that word, honestly. And going back to something you said before, like the process of death, who knows the process of death unless you live in that world? Nobody wants to know it. We don't know it. We go there. We have no idea what the process of death is. And when we are told anything, a lot of times it comes, even with the hospice professionals, very clinical and not individually. Right. So it's told to you like a fact on Wikipedia. This is what happens. Well, you can't. I know that for a fact just because I may not be a doctor, but I know that one size does not fit all.
Well, I have to say that in the different hospice organizations that I've worked for or worked with, they don't get dementia even very well, and I've usually had to be the one to say, primary care doctors don't offer hospice to a lot of people who are living with dementia as often as even cancer. Definitely gets offered. Heart failure and kidney failure, not as much. Dementia, even less. And so I think that, palliative care, I think of it as it should be in everybody's care all the time. Like if I get a headache, I take a Motrin because it makes me feel better. That's palliative care. Going for my quality of life, that today I'm going to have the best day I can have. That's a philosophy, right? Now there's palliative and hospice as medical benefits as well. And so I think that's what you're talking about, is what is the hospice medical benefit? That's not so much the philosophy. That's a governmental reimbursement for the care you get that fits some criteria. And so there is a bit of one size fits all in that you have to meet the criteria, or you have to get the doctor to agree that you meet some criteria. But I love hospice because I love it in theory because of the benefits you get. You get more access to durable medical equipment, so the hospital beds and the walkers and all that gets kind of usually taken care of, and the medications that you need get taken care of, and you get I think that's where you get the holistic approach. You get the spiritual leaders, and you get the social worker involved, and you get the volunteers who really just are such loving individuals usually, and you get the bigger package. You might get pet therapy more often. You just get a different package of things. But I know but unfortunately we often only bring in hospice at the very, very end of life. So you only get 3 or 4 days, and then you really get kind of that medical push, which is what Don was saying. You're going to get offered morphine, and you're going to get offered Ativan, and and maybe that's not what we need.
Can I describe what I think palliative and hospice is from my point of view that I just learned? Okay, and you can tell me that if I'm wrong, because I'm going to be the voice of hospice for dummies. Okay, and that's me.
Because and this is not what you learned. This is what you experienced.
This is what I
experienced. Very different from what you just described.
Right. So when my mother was put into hospice, which was right out of hospital. And that was because of a weird event that happened in another emergency hospital where my mother was being told that such a long story, but they told me she was on life support and that I should take her, that we should put her into comfort care and let's let her die. And I said, if she's on life support, yes, of course, but she didn't die. And she didn't die, and she didn't die, and she wasn't ready to die. And so when they released her, they recommended that she go into hospice. So I didn't know the difference. What I found was when my mom got back to the facility, she had a G tube, but it's supposed to be temporary while she was intubated. When she got back to the facility, they said it was too invasive to remove it and that she's going to aspirate. I said, but she's not aspirating. I'm feeding her juices and smoothies and she's loving it. And they said, well, it's too much of a risk. Well, come to find out later, a G tube is much more of a risk of aspiration than anything else. And it causes a whole slew of problems. And I didn't want her on that G tube. I would have rather her aspirate from juice and drinking orally than anything else. And that would have been fine. I said, I'll sign a release. I don't care. But and at the end of the day, it came down to time. They didn't want to invest the time into getting my mother to be able to have an oral experience. When she went into the hospital now, they wouldn't take out her catheter, a Foley catheter, and I kept asking them to. She went back into the hospital hemorrhaging from that Foley catheter. And they weren't treating her wound. I asked for a wound doctor every single day. They never sent a wound doctor. And what I found out from the doctor in the hospital, he said, because it's not covered in hospice. She needs to be in palliative. So, and it wasn't about extending her life, Dr. Kenny. If someone is in pain from a wound, let's treat the wound and get rid of it. And then whatever her body's going to do on its own, fair enough. But that wound is not normal.
From this whole scenario, there's so many teaching points, right? There's just so many. One is you were not listened to, which was wrong. One, if they ever say to you, you can't have that because of hospice, and you want that, you say, I don't want hospice anymore. And you go right back to full coverage on Medicare or, back. So people should be told as soon as they sign up for hospice that this is a different, usually philosophical road and the direction we're going. And you can back out of it anytime you want. It is not etched in stone. Mm-hmm. And so you say, if I want this thing, then get me off of hospice. Get my mom off of hospice.
But they didn't tell me.
And
they never gave that option.
They kept saying to me, the hospice doctor.
I'm so glad we're talking about that here and now. Right now, we should be saying, you sign up for. So don't be so afraid to sign up for hospice because it won't often be like Susie's. I hope. I hope it'll be a much better experience.
Yes, God.
Right, and that's why we're here, right, to educate that it should be better than that. And anytime it is not what you are wanting, get rid of it. You can undo it like that.
But we don't know what they offer. From the dummy point of view, me, I didn't know that, because what I kept getting from the doctor was, the hospice doctor, I'll check into it.
And then
just not
so
telling
you just
me.
say to the so one, you say, then I don't want it, and then they'll get back to you so fast because the paperwork to undo it. Two, when people are at the end of their life, they still should get care, any kind of care, wound care, personal care. Yes. A wound may not heal at the end of life because the body doesn't have enough of the healing powers. But that doesn't mean we shouldn't take good care of that wound just to keep it clean and as good as possible so that it could potentially heal, and pain management for it. So both of those things should have been happening no matter what. So asking for, I'm a hospice medical director, and I have somebody with a wound, and they are getting wound care all the time. Maybe that's a Connecticut thing. I mean, every hospice in every state is a little bit different, but it's also that different hospices will offer different things. So if the hospice that you're in the state that you're in, and you say, if they say, I don't cover that, then you say, give me the names of 5 other hospices, and then you call up their people and say, do you do wound care? If that's what you want. And I know that's a lot of burden to the person that's doing it, but Susie, you were such a strong advocate, and so I can imagine that a quick 5 phone calls, or asking one of your friends to make that phone call, again, delegating some of the care out to some other people. Easy enough to say to one of your friends, please do me a huge favor and call these 5 hospices and ask if they cover wound care. And you don't have to give out any other information. They don't have to know anything else. I just need to know, do you cover wound care? So you have, we as individuals as consumers have so many rights, and you're not going to necessarily hear them unless you listen to some podcasts like this.
Thank you.
But,
I mean,
even worse, though, Suze, was also that they weren't even just saying they won't do it. Though it was, you were constantly getting, well, I'll look into that.
I'll look into it.
And then you'll never, and we
don't know.
Happen.
That's what I was going to say, is that we don't, as someone that's just entering into this world that is so foreign to us, I don't know that they're not going to look into it. I don't know if it's covered or not. I don't even think of that. I think that the charge nurse told me, your mom's wound is not a stage 3, it's a stage 4, and she needs to see a wound specialist. So I say to the hospice doctor, and she says, well, let me look into it. And then when finally down the line, when one of the doctors at the hospital says, we're going to put your mom back into palliative because that's when they'll cover it. And it wasn't until it was too late to, $1 short and a day too late, because, they put her on a wound vac and all these other things. But there still wasn't enough. It was like they just put the wound vac on. And I remember going in there because I went every day, and I was like, the wound vac is off. Does anybody know why? No, we don't know why. Can I talk to the wound doctor? I mean, I never talked to the wound doctor. She finally called me, and she goes, oh, well, it shouldn't be off. And I go, well, it is.
So whenever you're in either hospice outpatient or hospice inpatient or palliative care inpatient, whenever you're in the medical system and you're not getting the answers you want, there is either a social worker that's involved. Ask to talk to the social worker, because they're like the team builders. So hospice has social workers. Palliative care has social workers. Hospitals have social workers. Whenever you're in the hospital and you're not getting what you need, talk to the social worker to be kind of the go-between exactly
the liaison.
Right.
However, I'm going to keep playing devil's advocate, because the social worker in the hospice was useless.
Oh.
Useless. And literally I would get like a phone call or an email like, hey, I just came to see your mom. She looks comfortable, and just wanted to let you know she was sleepy most of the time, but she was comfortable. And so if you have any questions, let me know. When I would show up, the room was hot as hell. My mom was, of course, because she's not getting oral care, so she can't even open her mouth because it's so full of gunk. I have to pry the gunk out first, and she was anything but comfortable.
You needed a brand new hospice.
Do you know what I mean?
So whenever
didn't know that was even an option.
But we didn't know, and I'm in a 5-star facility that is beloved here in Los Angeles, beloved. So how would I think that there's any better? And everywhere I talk to is like, this is the system, Susie. You have to. That's why I was under so much stress, because I thought I'm the only line to comfort she has, because I can't rely on anybody. I had the charge nurse at night when my mom went back to the palliative saying, if she goes to the hospital, don't bring her back, Susie. You're a good daughter. You've done so well. Don't bring her back here. We can't take care of her. And I'm only saying, I'm not trying to negate the system. The system,
it's
the
broken
way
in
it
all kinds of
reads
places.
is broken. Right. It's broken, because what it's set up to do is beautiful. And there are other. I know there are. Listen, the audience. I know that there are hospices that are fantastic, and they do what they're supposed to do. They are the minority, unfortunately, right now, and that's because the system is set up to make money, and that's the problem.
And the other thing I would recommend, and I'm sure maybe I'll get hate mail now, but your best bet is to go for not-for-profit hospices first. They're usually smaller. They're usually not. They're usually working at a loss, and they're compassionate. Yeah.
But just to know that, just the information that, you can choose your hospice. I mean, we really didn't even know that was an option at the time.
And they're supposed to tell you
that. It's like, no, this is what happens.
Right. And often,
this
if you're in a
is,
hospital, they'll offer you the one they're the most familiar with. And anyone who is being offered hospices say, please give me 5 choices. And if they say, I don't have 5 choices, then give me 3. But do not give me 1. And then you can And
Right.
you can look into.
That's really.
And then I
valuable to
would
know.
personally, I would look for the one that's a not-for-profit first, and go with that.
And what is the difference between palliative? Like, I guess I'm not seeing quite the difference. What is the difference?
In the difference, again, what hospice is a subset under a palliative philosophy. But if you're talking about palliative as a medical benefit, palliative is just a construct that the medical system, that an insurance company, whatever insurance company you're working with, has decided to call it palliative. It isn't actually anything special. It's that insurance company has earmarked extra training for the people in that area or whatever, but it's not its own medical, it's not its own insurance. Hospice medical benefit is the only thing that's special. Some visiting nurses or some health care organizations have decided to carve out a piece and call it palliative, and that's why basically they're just going back to regular insurance to cover everything. But
oh my goodness, that's so good to know. Yeah. Guys, this is so good, because I thought it was a separate thing, and the way that it was defined to me, even by the doctor, that was attending my mom, was saying, send her to palliative, not hospice. So I was like, but what's the difference? Because I thought it was an umbrella of hospice too.
No,
but hospice, they seem to cover the WIC. They seem to cover things that the hospice wouldn't.
Because you're back to regular.
And do more treatment, and actually do more medical treatment.
Yeah.
Right.
And at the end of the day, I didn't want to keep her alive longer than she would naturally. I wanted not to hasten it, was my goal. I didn't want to give up on her because she was too labor intensive.
Right.
And I knew I was up against the staff.
The system, right.
The system. And I kept saying to them, like you said, even there's in our medical community, they don't, even in hospices, they don't understand dementia. I had the chaplain come in to talk to me, because every time I asked for something, they'd send the chaplain. And she said, I was like, oh, okay, here we go. So she would tell, and at one point she said, your mom's demented. And so it's not like I know what you're feeling, but your mom, I want you to know, she really doesn't know what's going on. She has holes in her brain. And and I said, stop. I said, you have to understand, I've been in this community I'm not a doctor, but I really know Alzheimer's. I really understand it.
Right.
And I said, first of all, she's not demented. She has dementia.
Right.
And I said, and she knows I'm here, and she hears you right now.
Yep. And you can leave right now.
Let me show you video.
Yeah. And
you can leave right now. Thank you.
Yeah.
There's only one person here who has holes in their brain, and she's about to leave.
And that's you.
Right. So go bye-bye.
Don't talk about my mom like that.
I think that, and people don't understand, because words are powerful. And there's a connotation to demented. Demented is a very sick word, and I don't mean sick physically. Right. It
has negative connotation.
Deranged.
And so with dementia, we're fighting the stigma. You were fighting the stigma around death, that most of us don't talk about death. So you weren't able to have complex and complete conversations around it, because people are either avoiding it by pushing it on faster or avoiding it by denying it. But you were trying to have a conversation about how you envisioned your mom dying. And that's a valid conversation. Yes. And you needed to have it with people who were willing to engage in a conversation with you. And unfortunately, that wasn't happening. And people don't like to talk about dementia either, because we're just not at that place yet. Just like they didn't 50 years ago talk about cancer. But you're changing
exactly.
that.
There's
Thankfully,
such a bias.
You're changing
There's
that.
a bias.
Right. And your podcast and your documentaries are changing that so that we don't need to shove people out of our sight. We need to respect who we all are. It's a human right? We're talking about human rights, and that's all we're saying.
Yes.
Life isn't all about easy conversations all the time. We need.
No, it's not. And And again, going back to what you said, which is so true, it's not one size fits all. I mean, if someone gets agitated and they're violent, like you might have a very strong man who's having a problem right now with his dementia, and he does get violent, and he might hurt himself or someone else. There's a time and a place to use medication to help make his life more.
And I would argue that
copacetic.
Yeah, but I would argue that oftentimes we go with medications that are not approved, and we don't try to treat pain first, or we don't look at his meds and see if could this be a side effect to the medicines that he needed as a 50-year-old, but he may not need anymore as a 70-year-old living with dementia.
Exactly.
I mean, we don't look at it as in the complexity. We are complex human beings, and we don't necessarily take the time and the energy to look for that complexity. And I say it's creative. Look at the people you're taking care of, whether it is a caregiver or as a health professional, with some creativity, and it flips the whole thing to, I don't have time for this, but ooh, what a great challenge this is, and can I tease out what's really happening and get it right? I find it fun and fascinating, and I did it. I mean, I was plenty tired as a caregiver a lot of times, but in the morning, I mean, luckily I got a great therapist when my mom was going through dementia, and I was going through the dementia journey with her, and who basically taught me to sit in meditation. And it was during those times that I'd think that things would bubble up, like to better care for my mom when when my brain wasn't stressed out, when I could quiet long enough and not think that true answers would come up. I really learned to live much more from my heart, and as a physician, I guess I had been doing that, and I hadn't realized it until, but much more after my mom was living with dementia. I think I became much more compassionate doctor as well.
You were you would have been a very, probably not, I don't know how different, because you have so much within you already, I think compassion and all those things you would have probably come along maybe down the line, but what a different experience you've had as a doctor now because of what you went through.
Again, the transformation my mother provided me through her journey with dementia, as much as I did, I wish she hadn't had to go through it. The amount my siblings and I learned, and I've been, and my goal now is to try to give back, much as you guys are doing through your journeys. I just hope to make it easier for the next group of people. And I think my piece is that I do have kind of that both the medical and the caregiver. I'm sorry, Susie.
I know, it's beautiful. No, not at all. I want to talk about just one other thing about, doctors and healthcare workers, because I was talking to a doctor for my documentary, and she was saying how she's an emergency doctor, an ER doctor, who loved her career, went into it with such, joy and motivation and, high hopes. And she said it's almost that she can't see herself retiring in this field anymore, because it's so hard on her emotionally, and there's a stigma of getting therapy as a doctor, or can you talk about that so that we can get an understanding of what's going on there with doctors and taking care of themselves emotionally?
I think there's a stigma about therapy in the United States, period. I mean, I think we are cowboys, this is the U.S. is known for being fiercely independent, right? I mean, that's kind of what we were all raised on. So I think to admit that you might need some help in some way, shape, or form, especially mental help, is a sign that you're not as strong. And then there is just a conditioning in medical school, because you are going to learn so many things so quickly, and they're life and death things, that it's much like, I'm sure, military boot camp. There is a breaking down and building back up to be in the to be ready for whatever medicine throws your way. because you often are the last one to make that decision. So I think that's a part of it. We're in a nation that is known for being independent, and we're in a profession that is been put to be required to make rapid fire decisions, especially in emergency room medicine. I'm sure it's even worse. I mean, I'm a primary care doc, geriatric, and then specialty trained in end of life. So I probably have a little more woo-woo, touchy-feely, background. And it's no surprise that I went into that and that I'm open to something like therapy. Because for me, it's just like, why wouldn't I go talk to somebody who might have a broader view of how to make me become the best I can be at something? So I guess I look at therapy not as something to be ashamed of, but for me, it's just about how am I going to personally grow more and become the best that I can be. And I was struggling with being in academia at the same time my mom was starting to get sick. I was writing grants, writing papers, doing research, teaching classes, and taking care of people, and raising a young family. And that's a lot. And so I thought maybe the therapist can help me out. And oh my gosh, she gave me some tools that definitely helped me in the dementia journey, with meditation and journaling, because there's so many emotions that come with being a caregiver to somebody who may one day love you up and the next day not know who you are, and the next day be angry.
Call you a whore.
All because of the disease, right?
Or the next minute.
Right. Okay. Yeah. Right. And so, and I knew I shouldn't take it out on my mom, but sometimes it was like getting smacked in the face, and I needed, and so between meditation and journaling, and then having her for me for an hour a week, was building kind of some sacred time for me, which I think a lot of caregivers think, no, I'm only going to give. But if you don't feel you're well, you can't keep giving. So, I went into a depression taking care of my mom and keeping a high pressure career and raising a family. I am one of the caregiver statistics, and I knew better. I knew you shouldn't push yourself that hard because you'll break. I broke. And I'm,
because that comes out of the fear of guilt, because you don't want, it's like, if I'm not caregiving 24/7, I'm not caregiving. But you are.
And if you don't fill yourself, and if you don't build a team to help you with that, and whether that team is for you or the person you're, like some people say, oh, only I can care for my mom. Well, then build a team for you, because if you won't build a team for her, you better have one for yourself, because somebody's got to do some of the backfilling. And I think it's so important, helpful that I lived through the caregiving experience. So when I'm counseling people, I can go, you think you're not going to break? I didn't think I was going to break. Yep. And I knew better. I really knew better. And I did it anyway. Yeah.
Well, you're also, you're an ambitious human being too, on top of it. So you've got very rare, combination of empathy and emotion, and then you're also academic and you're driven, and you're, you've got it. You got it all. So sometimes we think we think we're stronger than we are, just because it's just we think we can do. And I didn't like that. I feel like I just kept going and going and going and going and going.
But it takes its toll, right, Susie? It takes its toll.
Do you think it takes its toll physically as well?
Absolutely. Studies after studies show that people living with dementia are much more likely to have medical conditions, comorbidities. The rate of dying goes up for caregivers who don't care for. It's specific. It's for those who don't care for themselves. And the number one thing that helps caregivers is building that sense of community, building a community to support them. Those people do the best of all, so that their sense of burden in the caregiving. Because, just like raising children, there's parts of that are boring. Well, there's parts of caregiving somebody living with dementia that are boring and tedious and and repetitive. I mean, it isn't always sunshine and flowers. It is at times, but not always. And so, it takes a physical toll. The stress, your body can't take that much stress all the time, and it will show up as heart disease and stomach problems and changes in your biome, and it's hard on it. It's a hard job.
It's a super hard job. Yeah, well, you're doing so much, and I just feel fortunate that you're out there teaching and modeling how to be a good doctor. It is hard, and I don't mean that in a disparaging way, because I've been in enough emergency rooms and hospital rooms now to feel the stress that health workers go through. So I have such a big respect and compassion for all of them. And thank you so much. And thank you for sharing your positive and intellectual prowess with us, because it's really lovely and reassuring. And
you're sharing all your wisdom on your website, Together in Dementia.
And her book.
Yes, Making Tough Decisions About End-of-Life Care and Dementia, which is, I think you can get it on Amazon. Is that correct?
Yes. Yep.
You just got a little bit of a taste of it today.
And what a soothing voice you have on the sideline.
Well,
I mean, right?
Yeah.
Oh, thank you.
Yeah.
And your whole demeanor.
Your demeanor, it's like, it just feels so comforting. You're just you're like a warm pillow. You are.
Thank you.
So anyway, thank you guys so much. And, you were saying about our podcast is about love. Love conquers Alz. And it really does come down to that, because love is so powerful. I saw it with my little 2-year-old granddaughter, who spoke no words to my mom, but climbed into bed with her in her room, and the two of them had a complete conversation. We don't know what they said, but there was a lot of kissing going on. And that's, so what do we always say, Dawn?
Well, that love is powerful, love is contagious, and love conquers Alz. We thank everyone for joining us today. Like, share, do all those things that so more people can see people
it's a
like
loving
Dr.
thing.
Ann Kennedy.
Yeah.
It is, absolutely. And we hope you'll join us next time, and have a wonderful rest of your day. Take care.